Hello, my name is Sayed and I will present patient case. We have a patient presented in the clinic with a complaint of depression. Richard Taylor is a 54-year-old gentleman presented in the clinic with a severe sign of depression that started almost 3 years ago when he had a cardiac event. However, the last 6 months has been incredibly tough for him. He has no interest in his hobbies and has constant feeling of guilt, fatigue, and worthlessness. Also, he is less inclined to spend time with his friends and recently had trouble in concentrating at work. RT has no sign of suicidal thoughts, bipolar disease, mania, or anxiety. He does not express any symptoms of insomnia. He tried citalopram in the past but had to stop due to erectile dysfunction and diarrhea. RT like to get a treatment for his depression if he can have a control on his depression. He may quit smoking and go back to exercise routine. His other medical conditions include obesity, dyslipidemia, myocardial infarction, COPD, and he's an active smoker. We don't have any information about his drug allergies. The medication he's currently on is metoprolol succinate 50 mg once a day, albuterol 2 puffs every 4 hours as needed for shortness of breath, atorvastatin 80 mg PO daily, fluticasone 100 microgram one inhalation twice daily, aspirin 325 milligrams daily. His social history includes he's a current smoker and he smokes 1 pack per day. He drinks alcohol occasionally. However, he has been drinking more in the last 2 weeks. He does not exercise. His diet has increased calorie intake in the last 3 months and have gained 15 pounds in the last 6 months. His family history consists of depression and cardiovascular disease. The prioritized problem list we have as number 1 priority today is depression, COPD, and his smoking habit. The last priority today is myocardial infarction and dyslipidemia. Moving to the assessment of disease, starting with depression. As per DSM-5 criteria for depression, patient has severe depression. This is evident by the fact that patient has depressed mood, anhedonia, loss of energy, worthlessness, and guilt for over 6 months that fulfill the DSM-5 criteria for depression. The contributing factor for his depression is the recent passing away of his wife, family history of depression, his deteriorating health. Patient is compliant with all of his current medication for different diseases. Patient would like to get a treatment for his depression that will improve his overall health. Patient tried taking citalopram in the past but had to stop due to side effects such as erectile dysfunction and diarrhea. Considering all these factors, the goal for the treatment is to manage his depression that will help him to take control of his life again in a span of few months. Moving to assessment of current therapy. Currently, patient is not taking any medication for the treatment of depression. 2 years ago, patient had tried taking citalopram that worked well for his depression, but it did not go well as patient had side effects such as ED and diarrhea with the use of citalopram. There is a need to start an antidepressant and psychotherapy such as CBT that will help treat his depression. Assessment of planned therapy. Citalopram 40 mg is not an appropriate choice for the treatment of depression in this patient. The usual starting dose of citalopram for the management of depression is 20 mg in individuals less than 60 years of age. This dose can be gradually increased to maximum 40 mg, depending on the response and side effects. In addition to this, currently patients have increased QTc of 457 millisecond. This is important in light of 2015 FDA drug safety report that highlight the fact that citalopram is associated with QT prolongation. The goal of therapy is to achieve remission of depressive symptoms and restored optimum function in about 6 to 12 weeks. The contributing factor for his depression is his continuous deteriorating health since 2015, recent passing away of his wife, and his also history of depression, family history of depression. The plan I have is starting with recommendation number 1 is start venlafaxine 75 mg PO once daily for 4 weeks. Depending on this response and side effect, the dose can be increased after 4 weeks in the increments of 75 milligrams to a maximum dose of 225 milligrams once daily. The rationale behind that is that, as per APA guidelines for depression, venlafaxine is the first line of treatment for severe depression. Venlafaxine is also safe and effective choice in patients with history of cardiac events such as MI. Venlafaxine is also not associated with QT prolongation, and it is important in this patient as he has a history of QT prolongation. Recommendation number 2, start CBT session with a therapist at least once a week for 6 to 10 sessions. As per APA guidelines, CBT therapy along with pharmacotherapy is more effective than pharmacotherapy alone for moderate to severe depression. Antidepressant usually takes few weeks to start showing its effects, and CBT session will help patients to cope with these symptoms of depression during and after this time. The monitoring. The efficacy of the treatment of depression in this patient can be monitored by the improvement in energy and concentration in 2 to 3 weeks of initiating the therapy. If there is no sign of improvement in symptoms of depression in 2 or 3 weeks, we need to reassess the patient and increase the dose of venlafaxine. From week 4 to week 8, patients will see improvement in the feeling of worthlessness with the continuous of antidepressants. Once beneficial effects are seen from the treatment should be continued for at least 12 months. The safety of the treatment can be monitored by the sign of nausea, insomnia, dizziness, which is a common side effect with the use of venlafaxine. The patient education. The most important point is the adherence to the treatment of antidepressant. Try to concentrate to work, as may give purpose to patient's life. Avoid use of alcohol with the use of antidepressant. It may decrease the efficacy and augment the side effects of antidepressants. Moving to patient's second problem, the COPD. Assessment of disease. As per GOLD guidelines, patient has uncontrolled moderate COPD. This is evident by the fact that patient's FEV1/FVC is 0.63 and predicted post-FEV1 percentage is 52%, and by COPD CAT score of 21. Moreover, patient complains of mild shortness of breath and trouble breathing while exercising. He does not exhibit any sign of bronchitis with his COPD. The most important contributing factor for his history of COPD is the fact that he smokes 1 pack of cigarette per day. Patient is currently compliant with all of his current medication and wants to change his life and his overall health. Considering all these factors, there is a need to modify his treatment for COPD to prevent disease progression and improve exercise tolerance. Assessment of current therapy for COPD. Currently, patient is using albuterol, 2 puffs as needed for the management of shortness of breath and trouble breathing while exercising. Albuterol is an appropriate choice for the symptomatic management of COPD symptoms. As per GOLD guidelines, SABA should provide to all individuals that are presented with symptoms of COPD, as it improves FEV1, dyspnea, health status of the patient, and also the health status of the patient. Patient also takes fluticasone for the management of his COPD. Corticosteroid without LAMA and LABA would not be an appropriate choice in this patient. Assessment of planned therapy. Currently, there is no planned therapy for the management of COPD in this patient. Patient currently taking albuterol and fluticasone for the management of COPD. As per GOLD guideline, albuterol is a recommended treatment. However, there is a need to reassess the use of fluticasone and substitute with something which is like a first-line treatment. The goal of therapy in this patient is to prevent progression of COPD, decrease respiratory symptoms, and improve exercise tolerance. The most important contributory factor for COPD in this patient is his smoking. Recommendation number 1 for the management of COPD in this patient is to stop fluticasone inhaler and start LAMA, such as tiotropium in 18 micrograms inhalation once daily. LAMA, such as tiotropium, is considered the first line of treatment in patients presented with dyspnea due to COPD. Once daily dosing will provide better compliance to the patient. LAMA treatment improves symptoms and health status. And LAMA also improves the effectiveness of pulmonary rehabilitation and improve exacerbation-related hospitalization. Fluticasone is considered second line of treatment in patient and should be stopped at this point. Recommendation number 2 is to educate patient about tobacco cessation. Tobacco cessation is the single most important intervention to slow down the decline of lung function. This helped patient to gain the control of his life again, as this was his primary goal for seeking medical help. Smoking cessation is the key to success for the treatment in patient with COPD. Patient also should recommended to get his influenza vaccine yearly, and along with that, he should also get his pneumonia vaccination. And the plan for that should be that patient should get his Prevnar 13 followed by Pneumovax after 2 months. GOLD guidelines recommend influenza and pneumonia vaccination in patient for COPD, as it prevents the lower respiratory tract infection. Moving on to the monitoring, the tiotropium is a very well tolerated medication with minimum side effects. The most common side effect with the use of tiotropium is the dry mouth, constipation, and blurred vision. The efficacy for the management can be seen by the improvement in exercise tolerance and his FEV1 and FVC score. The patient education points I have, the most important are avoid exposure to polluted air and dust. It is important to go over inhaler technique with the patient and encourage patient for physical activity to improve overall health and prevent disuse atrophy. Last but not the least, patients should know the sign of worsening symptom of COPD and seek help right away. Thank you.